This conference will now be recorded.
Welcome in, everybody. For today's lecture, we are going to be talking about pathophysiology, which is correlated to Chapter 8 within your textbooks. So with pathophysiology, what we're going to be talking about is how the body actually functions, and we are going to specifically correlate this to perfusion, and for us as EMS providers, what we can do in order to maintain perfusion. So our objectives throughout this lecture, we're going to talk about cellular metabolism, the components needed for adequate perfusion, and then also our blood volume and circulation. So this is a relatively complicated component within emergency medical services. Like I mentioned within our anatomy section, those who understand anatomy and understand pathophysiology make the greatest EMS providers. So if you need to rewatch this lecture, if you need to rewatch the anatomy, dive into it deeper, remember on my Brady Lab, there's also some different videos and also 3D animations that really help you understand and grasp this subject material. So first, we're going to talk about cellular metabolism. So remember, cells are the basic function of any human system. With those cells, they make up tissues, tissues make up organs. So in order for those cells to create energy, to replicate, to make those tissues and make those organs, what they need to do is metabolize that glucose in order to produce energy for the cells itself and also for the rest of the body. So definition of cellular metabolism, it's going to be a process in which the body cells break down molecules of glucose to produce energy for the body. Now remember, glucose basically is sugar components. Now, there are two ways in order for the cells to metabolize and create that energy. First, aerobic metabolism. This is going to be the breakdown of those molecules through a series of reactions that produce energy within the cells, and we have the presence of oxygen. So this is the best case scenario for us to perfuse properly, where we have oxygen inside the system. The body's going to metabolize the oxygen and that glucose molecule, and as a result, we are going to create a very efficient amount of ATP or energy. That is the end game of metabolism, is creating an adequate amount of ATP. Now, as a result of this procedure, we are going to create some waste. So we are going to create waste in the form of carbon dioxide and some other components. Now, where we see our patients really get into trouble, and for those of you who have participated in sports or worked out heavily and received cramps, this is the rationale why. Rationale why is anaerobic metabolism. So again, somebody gets themselves into trouble such as severe illness, severe trauma. Their body still wants to metabolize and it still wants to create that energy. However, they are not perfusing adequately or they are not breathing properly. As a result, we see that oxygen content in the system deteriorate. As a result, that body is going to switch from aerobic metabolism to anaerobic metabolism. Now, anaerobic metabolism is the breakdown of those molecules in the cells without the presence of oxygen. As a result, we do create a very small portion of ATP or energy, but we also create a ton of waste material, which is bad for us. So think of, as a comparison, old cars in which, they would get 12 miles to the gallon or 10 miles to the gallon and create a ton of waste that was bad for the environment. Now with new cars, we're able to go a lot farther on that gasoline and then emit a small amount of waste material into the air. So that's basically what's happening inside the body. With aerobic metabolism, we have the high technology cars. With anaerobic metabolism, we have the out-of-date cars that create much more waste and are much less efficient. Now pay attention to the video because it's going to walk you through that aerobic and anaerobic metabolism, and then also that cellular transfer in between the cell membrane.
We use glucose as fuel for the body. Glucose provides energy in the form of ATP so that cells can perform their function. In order for this to occur, glucose must undergo catabolism. Glucose is broken down under the following two different conditions: anaerobic, meaning without oxygen, and aerobic, meaning with oxygen. The first step of carbohydrate catabolism is glycolysis, and it occurs in the cytoplasm of human cells. Glycolysis is an anaerobic process. In anaerobic catabolism, glucose is broken down through a series of chemical reactions into pyruvic acid and then into lactic acid. Because most of the energy remains within the lactic acid molecule, this totally anaerobic process of glucose catabolism yields little ATP. The focus of this demonstration of glucose catabolism will be on the aerobic catabolism of glucose. If oxygen is available, glucose is broken down during 3 series of chemical reactions and ultimately forms carbon dioxide, water, and energy, or ATP. In this process of glucose catabolism, glucose is first broken down to pyruvic acid in the cytoplasm. Glycolysis splits one molecule of glucose into 2 molecules of pyruvic acid. This portion of the process is also anaerobic, and a small amount of ATP is released as well. However, as the breakdown of glucose continues to the next step, the citric acid cycle, oxygen will be required, making it an aerobic process. Electron transport. Carrier molecules transport the high-energy molecules to the electron transport system, which is a series of molecules along the inner mitochondrial membrane. In a chain-like structure, they transport electrons that have originated from glycolysis and the citric acid cycle from one molecule to the next. As electrons are moved along the chain, other molecules combine to form water and ATP. The final result of the aerobic reactions in the mitochondria is the production of carbon dioxide, water, and energy. Some of the energy forms ATP. The remainder is released as heat.
So in that instance, it goes into a little bit more detail than for us as EMS providers we really care to know, but it gives us a good understanding of exactly, what's going on inside that patient's body. So next we are going to talk about the components needed for perfusion and how we as EMS providers can help facilitate that perfusion throughout that patient. So we are going to break these down one by one. We're going to talk about the composition of ambient air, a proper patent airway, the mechanics of ventilation, how that ventilation is regulated, ventilation to perfusion ratio, how the body actually transports that oxygen coming in and then eliminates that carbon dioxide going out, the adequate blood volume circulating through our system, pump function, vascular resistance, microcirculation, and blood pressure. So first, in order for us to be alive and perfuse adequately, we need enough oxygen in the air to actually create that aerobic metabolism state. So in the air right now, we have about 21% oxygen. Where we get ourselves into trouble is if there's a depletion of that oxygen, if there is a different chemical inside the air that's actually hindering the oxygen, or if there's too much oxygen. So common instances where we would find ourselves responding to instances like this is going to be confined space issues, where there's a additional chemical inside that confined space, or there's not enough oxygen in that confined space in order to adequately perfuse. The majority of ambient air is going to be made up of nitrogen, which is 79%. And then we also have a few chemicals that make up that additional 1%. So we can see that ratio. Again, we need about 21% oxygen in order to maintain that proper ventilation cycle. Nitrogen is going to maintain the majority of that composition, and that's why they put nitrogen in SCA bottles and scuba bottles as well. So next, we're going to talk about the patency of that patient's airway. For us, this is one of the best things that we can possibly do for our severe trauma patients and our severe medical patients, is really focus and maintain the patency of that patient's airway. Now, for our unconscious patients, the leading cause of airway obstruction is going to be that patient's tongue. So when we start talking about airway management and oxygen administration, we're going to talk about a couple of different techniques in order to maintain that patent airway. Now, other culprits that can create that obstruction for that patient are obstructions such as choking. Patient gets a piece of steak stuck inside their trachea. They're not able to adequately get that oxygenation in. We also have a variety of different disease processes as well. So upper airway obstructions associated with diseases such as croup, epiglottitis. We could also see lower airway obstructions such as COPD and asthma, pneumonia, in which those disease processes are also eliminating that patient's ability to adequately maintain that patent airway. So next, we have the mechanics of ventilation. So a definition of ventilation is going to be that mechanical process that relies on changes in pressure inside the thorax to move air in and out of the lungs. So basically all of our body components, it's a continuous change in pressure. They go from high pressure to low pressure to high pressure. And we can see that in the Boyle's law. So an increase in pressure, or more positive, will decrease that volume of gas. So that's the definition of Boyle's law. So a decrease in that pressure, more negative, will increase the volume of gas. So think of it as a teeter-totter. We're constantly teeter-tottering between a higher increase in pressure with a lower decrease in volume of gas, and then vice versa. And that's how we bring oxygen inside of our lungs. So then we need to regulate our ventilation. So the mechanics of that ventilation, our chief muscle group that we are going to utilize in order to create that negative pressure and positive pressure of air coming in, is going to be housed by the diaphragm. Now we notice on our kids, our pediatrics and our infants, that they predominantly breathe with their abdominal muscles and different muscle groups that we don't normally see with our adult. The rationale behind that is the fact that their diaphragm is not fully developed at that point, and as a result, they have to rely on some other muscle groups that are more predominantly regulated at that point in their life. So how we regulate how fast we breathe and how slow we breathe. These are all based on chemoreceptors. So chemoreceptors are specialized receptors within the system, and there are two predominant chemoreceptors that help regulate us breathe. We have central chemoreceptors and we have peripheral chemoreceptors. So we'll talk about the central receptors first, because the majority of the population regulate their ventilation based on our central chemoreceptors. So they're going to be located near the respiratory system in the medulla. These are most prone to changes within the amount of carbon dioxide in our system. So if we start getting an increase in carbon dioxide, we are going to start increasing our ventilations in order to blow off that carbon dioxide. Vice versa, we have low carbon dioxide, we are going to breathe slower at that point. Again, the majority of us are going to be breathing based on that central chemoreceptors. Individuals that we see breathe based on their peripheral chemoreceptors are more susceptible to our patients who have COPD, chronic obstructive pulmonary disease. The peripheral chemoreceptors are much more susceptible to changes in the oxygen content of that patient's system. The reason why COPD patients transfer from central receptors to peripheral chemoreceptors are for the fact that they often go into the hypoxic drive. So this is where those chemoreceptors are located for that patient. Now, diving deeper into the hypoxic drive for our COPD patients. Again, normal patients are going to rely on those changes in CO2 in order to regulate that rate and that depth of those ventilations. Well, with patients with COPD, they have a continuous buildup of carbon dioxide inside their system. And as a result, that central chemoreceptor area begins to shut down. And now they're going to switch over to their peripheral chemoreceptors. As a result, our patients are going to start breathing based upon their oxygen content in their system, which is going to regulate our ventilatory rate and then also the volume of air that we are taking in. So for our COPD patients, there are two primary culprits behind this. We have chronic bronchitis, which, if we reflect upon our medical terminology, chronic is a root word and it is going to be describing long-term. Bronch is going to be another root word, and that is going to be our bronchioles, and then itis is going to be our inflammation. So we have long-term inflammation of the bronchioles, and then we also have an excessive buildup of mucus in there. So we can see the difference between the healthy bronchiole, in which we have that nice wide open passageway in which oxygen can come into the system, and then carbon dioxide and other waste material can then leave that system through expiration. With emphysema, a little bit different. This disease is actually going to attack the integrity of the alveoli. So the alveoli is where gas exchange is going to take place, where we have oxygen coming in, we have carbon dioxide going out, and because of this healthy shaped alveoli, we can create proper gas exchange. Patient with emphysema, they're going to have that breakdown of that alveoli molecule, and as a result, that gas exchange doesn't take place as effective as it would with our normal healthy patient. So, with all that being said, hypoxic drive is going to be that patient who is going to be breathing based upon that oxygen content within their system. Now, for us as EMS providers, we have to be slightly concerned with how much oxygen content that we're giving to our patients with COPD. The reason behind this is somebody who's got COPD, they're breathing based upon their peripheral chemoreceptors, which are susceptible to changes in oxygen. If we give them 100% oxygen utilizing that non-rebreather mask, we could potentially increase their oxygen levels to 100% inside their body. And then their body's going to say, hey, I have enough oxygen content, I don't need to breathe anymore. As a result, their respiratory system is actually going to shut down at this point. Now for us in the pre-hospital environment, in which oftentimes we have a short interaction with our patients, we don't have to be overly concerned about the hypoxic drive. Where this phenomena actually occurs most often is going to be in the ICU or a long-term care facility where that patient is continuously blasted with that high flow oxygen and resulting in 100% O2 stats. So next, we are going to be looking at the ventilation to perfusion ratio. So this is a good segue from our COPD patients into this. Because even though we might be breathing adequately and bringing enough air in, we still on a cellular level have to perfuse adequately and bring that oxygen content in. So we can see the exchange that's occurring within this picture. We got oxygen coming in. That is the alveoli depicted in the top right. That is then going to interchange with the capillary beds, and then that carbon dioxide is going to be dropped off into that alveoli from that capillary bed. So we already saw in the event that a patient has emphysema, it's very difficult for that gas exchange to take place because we don't have healthy alveoli. Other hindrances that we could see is different disease processes that might affect the hemoglobin of actually carrying that oxygen molecule, which we'll talk about in the next slide. So the transport. So we need some type of transport that's actually going to be carrying the oxygen molecules to the different cells and tissues of the body. And then we also need that to carry that carbon dioxide away from those cells back to our respiratory system so that we can properly get rid of that carbon dioxide. Our oxygen transport is going to be facilitated by our hemoglobin or our red blood cells. Carbon dioxide transport, it's going to be dissolved within that plasma, and then again, it's going to be attached to that hemoglobin, and then it's going to work its way back through our system to our respiratory system. So here, as far as a ratio goes, this is what we're looking at. We're looking at the alveolar capillary gas exchange. So with each inhalation, that alveoli is going to be filled with oxygen-rich air and a small amount of carbon dioxide. So remember, from that first component, we need about 21%, and the amount of carbon dioxide that's coming in is going to be less than 1%. Then with the capillaries surrounding that alveoli, they're going to be filled with CO2 and that small amount of oxygen. And as a result, between the differences of pressure, remember, we're going to have a high amount of oxygen on one side of that capillary bed, low amount of oxygen on the other capillary bed. That high pressure is going to go to the low pressure, and same thing with that carbon dioxide, where we have a heavy amount of carbon dioxide on one side of that capillary bed, a low amount of carbon dioxide inside that alveoli, and that's how we're going to create that gas exchange. So here, a very basic fundamental picture of that gas exchange. We breathe in, that oxygen comes into the system, it goes to the alveoli, goes through the capillary beds, and then it binds to that hemoglobin. That hemoglobin is then going to carry that oxygen to the different tissues of the body. It's going to drop off that oxygen once it meets the capillary beds, and then it's going to take on that carbon dioxide, which is then dissolved into that plasma component. And as a result, it's actually transferred as bicarbonate. Then that red blood cell is going to work its way back to that alveoli, and then it's going to drop off that carbon dioxide. We exhale that carbon dioxide into the air, and then we take in more oxygen, and that cycle continuously repeats every time that we breathe. So we can see all of those components that made up the airway system. Again, it is vitally important as EMS providers that we master the ability to maintain a proper airway and maintain proper ventilation for that patient. So now we're going to start talking about the blood composition and then also the pump function that make up the perfusion factor of that patient. So with blood volume, for the normal sized adult, roughly about 5 to 6 liters of blood. Now this is going to be based upon a weight formula, which is about 1/11th conversion factor to properly assess how much blood volume is circulating through the system. So if we were to look at Andre the Giant, who was about 560 pounds, he had about 17.5 liters of blood circulating through his system. Now for our pediatric and our infant, infant who weighs about 9 pounds, they are going to have less than a pop can worth of blood supply circulating through their system. Now, as far as that composition of how that blood volume is actually made up, we have 45%, which is going to be our whole blood content or our blood composition. The remaining balance is going to be 55% of the plasma content, which is more of the watery substance that makes up our blood composition. Now, within that blood composition, we have 48%, which make up our red blood cells, white blood cells, and platelets. So red blood cells, they are going to carry oxygen to deliver to the cells for metabolism, and they are also going to be in charge of transporting that carbon dioxide back. Our white blood cells, they are the fight response within our blood composition, and they are in charge of protecting the body against any infection. And then they also are in charge of eliminating dead and injured cells. Platelets are going to be our clotting factor and bleeding control. So if we get injured and we are either internally or externally bleeding, our body is going to send our platelets to that injury site. Those platelets are going to start to group together, and as a result, we're going to create that clot in order to stop that bleed. So there we can see that breakdown of how much plasma we have, how much white blood cells and platelets compared to our red blood cells. So you can see plasma is the chief component that makes up the blood, followed by our red blood cells. Next, we have the pump function of the myocardium. So again, breaking down that word when we're referencing our medical terminology, myo is going to be muscle, cardium is going to be referenced to heart, so it is going to be the heart muscle. Cardiac output is going to be the amount of blood that's ejected by that left ventricle within 1 minute. So remember from our anatomy lesson, we have arteries and we have veins. Arteries, the majority of the time, are going to be carrying blood that is oxygen enriched away from that patient's heart. And then veins are going to be then transporting that deoxygenated blood back to that heart. So with cardiac output, what we're looking at is the amount of blood that is being ejected by the left ventricle that is oxygen enriched.
This conference will now be recorded.
Sorry about that, guys. I'm trying to hammer out this lecture before I have to go back to work, and I'm still at home with the dogs. So then with cardiac output, this is essential with our stroke volume and our heart rate. So our heart rate is going to be the number of heartbeats in 1 minute, and then our stroke volume is going to be the volume of blood that's ejected by that left ventricle with each contraction. So in order to measure cardiac output, what we're looking at is that heart rate times that stroke volume. Now for us, there's no way in hell that we're going to be able to actually see what somebody's cardiac output is, but by using a few tools in our toolbox, such as measuring perfusion as far as looking at their skin condition, are they pink, warm, and dry, and then also looking at their blood pressure and also looking at their mental status as well.
With each contraction of the ventricles, blood is pumped out of the heart. Stroke volume is the amount of blood a ventricle pumps out in one contraction. Cardiac output is the volume of blood that each ventricle ejects every minute. To find the cardiac output volume, multiply the number of heartbeats in 1 minute by the stroke volume. At rest, the cardiac output for an average adult male is about 5.25 liters, 4.9 liters for an adult woman. Cardiac output increases with physical activity, rising to a maximum that may be 4 to 7 times greater than the resting output. This difference between resting and maximum output is known as cardiac reserve. Heart rate and stroke volume are regulated by the autonomic nervous system and by hormones in the bloodstream. Other factors such as age, weight, and physical fitness also influence cardiac output.
All right, so with that one, we talked about the pump function of that patient's heart. And then attached to that patient's heart is our systemic vascular resistance. So how constricted, how dilated our blood vessels are. And then how we can tailor how wide and or how constricted our blood vessels are. So we can go into that fight or flight response. We're going to constrict those blood vessels. You know, when we rest and digest, oftentimes those blood vessels will then be more dilated. So as adults, we build up that systemic vascular resistance, and we can change the diameter of our blood vessels relatively easy with the stressors that gets put on our body. Now for our pediatrics and infants, when they don't have that vascular resistance quite built up yet, that's why we see lower blood pressure inside their system. From there, we need microcirculation. So definition, we're looking at microcirculation is the flow of blood through the smallest blood vessels. So this is going to be the arterioles, the capillaries, and the venules. So here we can see the arteries and the veins. So the arteries coming down, we have oxygen-enriched blood. They're going to make its way into these capillary beds. Oxygen is going to be dropped off. Carbon dioxide is going to be picked up, and then it's going to enter the venule, which then enters the vein, and then the veins are going to lead back to that patient's heart. Next, we have blood pressure. So a normal adult value for blood pressure is going to be 120/80. When a patient starts to get themselves into trouble, that patient is going to compensate, and oftentimes we are going to get an increase in blood pressure. So somebody who's bleeding internally or externally, we're going to increase our blood pressure in order to try and maintain that cardiac output. When that patient starts to go into decompensated shock and irreversible shock, that's when that patient is no longer able to regulate the vessel tone within their arteries. As a result, that's where we see that drop in blood pressure. So with measuring blood pressure, the systolic pressure is going to be measured when the heart contracts, and diastolic pressure is when it is measured when the heart relaxes between those beats. All right, so I know we went through a lot of information in a short period of time. So if you need to rewatch this lecture or look at those 3D animations as well on My Brady Lab. And then there's plenty of YouTube videos that you can see out there as well. All right, thanks everybody, and have a good night.